very warm welcome from the ESC Heart House in Nice, France. And we are talking today about the ESC and EACVI webinar on the topic of how to use multimodality imaging for transcatheter interventions. This is today's part 1, which will focus entirely on the mitral valve. I'm glad to have two experienced speakers on multimodality imaging, and to my left-hand side is Eric Brochet, who comes from the Hôpital Universitaire du Bichat from Paris, France, and he will cover the first part. And on my right-hand side is from our institution, Felix Kreidel, who is also very experienced, a long-term echocardiographer and in multimodality imaging and now in fusion from the Heart Valve Center of the Universitätsmedizin Mainz in Germany. These are our disclosures. We're setting the stage with this slide, which was published this year in the European Heart Journal, and it shows a dramatic change, a world of change, which comes from an open view in surgery, given with the green and gray bars showing surgical mitral valve repair in green and mitral valve replacement in gray. And on the red bars, you see the dramatic increase in Germany since 2011 of MitraClip procedures on the mitral valve, reaching also 6,000 procedures per year in Germany. Of course, there are other skills needed now in treating a valve via transcatheter pathway, and we'll now focus on these new aspects. And I give the word now to Felix Kreidel, who will describe the different modalities we'll touch today. Felix, please.
Also, a warm welcome from my side. Yes, of course, since we're not surgeons and we're not touching the heart, we need imaging to do our job. And number one imaging modality is fluoroscopy, a traditional imaging modality tested in many thousands and millions of procedures, has excellent imaging of catheters and devices, but gives you no information on soft tissue and depth. Then there's echocardiography, of course, that has evolved dramatically from a 2D cutting plane modality into an innovative 3D imaging modality that gives you a high spatial and temporal resolution and also information on blood flow and pressures. And then we have computed tomography with excellent spatial resolution of the heart of all 4 chambers. But when it comes to procedures and intervention, we only used one historic heartbeat that was recorded prior to the intervention. And to illustrate the scope of today's webinar, we give you these images, trying to stress that we have isolated information that has a long history for some, but not yet really online navigation. And we want to discuss today how far we are when it comes to treating mitral valves percutaneously. This is kind of a strategic slide, how we divide multimodality imaging, how we see it, and we see a big pre-procedural imaging part where it comes to assessment of the morphology of the mitral valve, also by 3D echo and CT. Then it is about planning the device type and the device size. It's defining and interpreting the optimal landing zone for our device. And what you also do pre-procedurally is planning optimal fluoroscopic projections. And the other part of multimodality imaging is then when it comes to interventions in the hybrid OR, and this is where we want to focus on fusion of fluoroscopy and offline CT information, and also on fusion of fluoroscopy and online echo information.
Thank you very much, Felix, and I think we will now move over. We already have the first questions, but I think we will address them because they relate already to the first 2 cases, and we'll discuss them after these first 2 cases. And I now hand over to Eric to show us in 2 patient cases, actually, a use model of multimodality imaging on the mitral valve. Eric, please.
Thank you, Stefan. So the first case is a typical example of a patient referred for assessment of severe MR for percutaneous treatment. He's a 78-year-old male with a severe mitral regurgitation with many comorbidities, multiple abdominal surgery for bladder cancer, chronic alcoholic pancreatitis, and chronic renal failure. And the cardiac history was moderate mitral regurgitation, known for many years, and a shortness of breath for 6 months, increasing in NIHA 3 and 4. So he was referred for assessment of this mitral regurgitation and discussion of a mitral clip therapy. Here you can see the transthoracic examination showing severe mitral regurgitation with an eccentric jet with area of 0.8, a left ejection fraction of 75%, a mean gradient of 4 mm of mercury, and pulmonary artery pressure of 45 mm of mercury. You can see also here on the transesophageal examination the mechanisms of mitral regurgitation, which is a prolapse, which very severe mitral regurgitation with an inversion of the systolic pulmonary flow. So with this information, it should be discussed if we have enough information to select this patient for percutaneous treatment. And do we know where and how severe the pathology is? It is only P2 prolapse, it is a Barrow's disease, it is a combined P2 and P3 prolapse, is it a vegetation, or I need more information, especially 3D information?
You're all invited to participate in this vote. It will be 1 out of 4 multiple choice questions to interact with you dynamically, and you have another 40 minutes to take your vote.
40 seconds, sorry.
40 seconds, not 40 minutes, I'm sorry, 40 seconds to take your vote. And we'll then discuss the answers with the upcoming slides and this patient case. So what are the hardest things to discover actually on those two-dimensional images? So I think for me at least it has been hard to differentiate truly number 2 and 3. How would you do that?
Yes, it is recommended in the guidelines and in practice to use multiplane imaging with 2D TEE to assess the different scallops of the valve. And it is sometimes difficult to assess the real extent of the pathology. And this is why we think we need more information, and especially 3D information.
We perhaps just get back to the
maybe we can see the vote also.
That we can see the vote, and the vote is very interesting, and I think the participants are actively thinking with us. So the 3 most predominant answers are actually, with the leading answer being 59%, that they need 3D information actually to definitely define the pathology. And looking back, as far as I'm doing webinars, and I'm using 3D matrix probes in 2007, which is now 11 years from now, this answer has completely changed over time. And on the other hand, about 17% thought it was an isolated P2 prolapse, which was given with the long axis view, but you're not able to really see the width of this prolapse. And 21% already recognize it could also be a combined P2 and P3 prolapse, which is excellent from these two-dimensional images to discover this. Vegetation was used in less than 1%, and also Barlow's was not actively given, even though there was some elevation also of the anterior leaflet. So I think it's an excellent vote here from our audience, and we see that we really have experts on the internet following this webinar. Absolutely. So you can now go on with number 5 actually as the prime hit.
Yes, absolutely. For skilled echocardiographers, of course, it is possible to differentiate P2, isolated P2 or P2, P3 prolapse, but it is now more easier to identify this pathology with the 3D en face view from the left atrium, which is called the surgical view. And you can easily see here the different scallop of the leaflets, P1, P2, and P3, from the anterior commissure to the posterior commissure, and the anterior valve here, close to the aorta. And as you can see, you can easily here differentiate P2 prolapse, which should be localized only here, from a P2, P3 prolapse here, which extended also with the P3 segment. So in addition to this 3D en face view, you can also use X-plane or biplane mode, which is very useful to study the extent of the pathology. Here you see that the X-plane mode cut from the commissural view a perpendicular view, and it gives you the coaptation plane here in A2P2, but you can deplace the cursor to sweep along the line and explore E1P1 or E3P3 segments and show the extent of the pathology. Another tool that can be used with a 3D dataset is a multiplane reconstruction tool, which is derived of the technique that is used in CT, for example. And with the 3D dataset, you can cut and reformat the different planes, align these different planes, and explore all the valve, all the segments of the valve. And you can also perform very accurate measurements on the valve, mitral valve area, but also mitral regurgitation. You can assess the regurgitant orifice, and so it is very convenient for the assessment of this valve. So the key learnings from this case are first that 2D echocardiography alone misses the full information on extensive valve pathology. 3D echo with full volume rendering and X-plane are very useful to localize and assess the extent of the pathology. And offline MPR moves like CT scan analysis allow also more complete analysis of this complex mitral valve.
Thank you, Eric, very much. And I think these were compelling and excellent images to really show the advantages of the multi-planar actually imaging. And I was also surprised to see that the commissural view in the sample that you gave was actually at 80 degrees, which is actually not the normal area where we look for. So normally we start with 60 degrees, but it also shows that hearts with pathologies may have rotations that leave the usual patterns actually of standard 2D views. And this also gives a very strong emphasis on the need to be anatomically correct, as you pointed it out, so that we know where the P1, the P2, and the P3 segments really are to analyze what potential therapy alternatives we will have now or in the near future. And I think you will show another very nice case. So there is one question regarding the MitraClip that we can already address a little bit. It is not focused so much on the imaging part, but again, of course, with MITRA-FR, and you took a very good case here because you took a degenerative case. So you put yourself out a little bit about the discussion that is ongoing since the European Society of Cardiology Congress in Munich this year with the use model or the mortality benefit in the MITRA-FR study. We all know also that there is upcoming directly now the results of the COAPT US trial. So I think the chapter is not written, and I'll give you the question. After all, who will receive benefits from MitraClip? And I think for degenerative disease, this answer is already given. Could you elucidate a little bit on that? You were in the core lab also for MITRA-FR, I think.
Yes, I think for degenerative mitral regurgitation, it is clear that it's a beneficial technique. And in this pathology, often the left ventricular function is normal. And when you correct the mitral regurgitation, you correct the disease. So it is a very good treatment. So in patients who are contraindicated for surgery, it is really a good alternative. For functional and secondary MR, we wait for the other trials. Now we have seen that the things are not so clear because patients who had functional MR are also disease of the left ventricle. So medical treatment also has a very important place in these patients. And we should see in the future if we can select the good patients for the MitraClip therapy.
And actually, MITRA-FR is not a big surprise, given the number of patients treated, and actually that in the last 30 years, we have no conflicting results in surgery. We would have hoped that the results would be better, but I think we should wait for 2 larger trials to actually enter the market, and we'll then finally discuss, perhaps in one of the future webinars, actually this hot topic, which addressed 6,000 people in Munich. We'll now move on, Eric, perhaps to case number 2, because this extends the scope onto what we can do in multimodality imaging. Please, Eric.
Thank you. So the second case is a 75-year-old female with a calcified mitral valve. Again, many comorbidities, a medical history of non-Hodgkin lymphoma, radiotherapy, triple cabbage, TRVR for symptomatic severe aortic stenosis, and the patient is also known to have a combined calcified mitral valve disease. She presented with a shortness of breath, with severe dyspnea leading to cardiac cachexia, and on physical examination, we heard 2/6 systolic murmur, no F3, no sign of cardiac decompensation. You can see here the transthoracic examination showing heavily calcified mitral valve and mitral annulus. You can see there is some degree of mitral regurgitation, but also mitral stenosis with the reduced mobility of the leaflets. You can see also the extent of calcification in the posterior mitral annulus. And with 3D transthoracic echo, we can see also that the calcifications are all around the mitral annulus. With the transesophageal echocardiography, we can very nicely see here the calcification of the annulus on the left atrial part of the annulus, and also the reduction of mobility and the mitral stenosis with a gradient, mean gradient of 13 millimeters of mercury. And you can see that there is a rigidity of the valve and also calcification of the valve. So the question here is, in this patient who has obviously a MAC disease, what additional imaging modalities do we need for therapeutic option? Do we need a CT with contrast or without contrast, because she has also renal failure, cardiac MRI, rotational angiography, or PET scan to rule out endocarditis?
Also, this vote and poll is open for voting, another 35 seconds, and I think this is also a very important question because it addresses the differences in different radiology tools, being MRI as a non-radiation tool that gives us also additional flow information, but cardiac CT, which could also have some additional information on the calcium distribution, which is excellent actually to see devices. Calcium has a very high resolution, and perhaps we'll address shortly also 4 and 5. There are 2 seconds remaining, and we look for the results. It's a quite distributed actually answer. So to start with the lowest percentage, this of course is PET-CT with a little less than 9%. Rotational 3D angiography was voted for in 13%. And actually there are 3 major choices, which is interestingly a pair between cardiac CT without contrast dye, perhaps referring to the calcium that could also be depicted without any contrast, and cardiac CT with contrast dye. Together they gain 50% of the votes and are epivocal, and cardiac MRI is actually been voted for in 29% of the cases. So quite interesting result on this vote. And perhaps, Eric, can you continue and perhaps include this a little bit in your further demonstrations?
Yes, the main discussion in this type of patient is what can offer in order to improve the status of this patient. Cardiac surgery is at very high risk in this patient due to the calcification of the annulus, and there is a need for transcatheter treatment, but the possibility to implant a valve in such a calcified disease need very careful screening, and CT scan with contrast injection is the best tool at the time to assess both calcification and also left ventricular morphology. So the parameters that have been to assess are the extension of calcification, are the calcification circumferential or not, the dimensions of the effective mitral annulus, and also an important point is the risk of LVOT obstruction after implantation of the prosthesis.
And perhaps we can shortly stop here and enter the discussion, because in the early experience, of course, we're using a valve that was originally perhaps designed for an aortic position. And also in Munich, there have been several implants, but there have also been fatalities. And you're nicely pointing out that one of the biggest reasons for fatalities was actually misregard of the potential turning of the valve directly at the implantation, but also over time in the ongoing months after implantation. And this major risk actually for death for this patient is ongoing LVOT obstruction. So tell us perhaps a little bit of how we can prevent it, because this behaves like an incomplete ring. So we have the problem that the anterior side is less well protected, and we don't use a specific, perhaps a specific mitral valve design, because there is not yet any CE marked transcatheter mitral valve replacement.
Yes, so the valves that are used are mainly transcatheter valves that are used for TAVI implantation. So it's a SAPIEN XT and SAPIEN 3 valve. And you need to have enough calcification, especially in the posterior and in the commissural part, but also in the anterior part of the annulus. In patients with radiotherapy calcification, there is less need for anterior calcification. But you have to accurately assess the dimension of the annulus, because sometimes the annulus is too large for this kind of valve. And there are now several software which allow a semi-automatic measurement of these values. And we can here measure the area of the neo-annulus with calcification of the annulus. And this is one important parameter to assess the feasibility of the technique. The second parameter, which is very important, is to assess the risk of LVOT obstruction. And with this software, it is possible to simulate the implantation of the prosthesis at different depths, and to look at the proximity of the anterior ventricular septum and to calculate the so-called neo-LVOT, which is the LVOT which remains in systole when there is a prosthesis in place. Another parameter which is important is the angle between the aorta and the mitral annulus axis. And if this angle is too acute, less than 90 degrees, there is a very high risk of obstruction. So all these parameters should be collected, and the best method is contrast CT with earth-educated, and you have to have all the phases of the cardiac cycle to assess
so a multi-phase CT that is covering 10 parts of the heart cycle to really see all phases of systole, but also diastole, because this neo-LVOT depends on the contraction of the left ventricle. Sure. Could you perhaps further highlight, because there's also another question on the neo-LVOT size, because some vendors of transcatheter trials have put up higher cutoff values, like 250 millimeters square. Could you comment shortly on this?
Yes, so there is no established cutoff value for patients with MAC implantation, but we know that in patients over 200 millimeters square, there is no risk of obstruction. Patients who have less than 100 millimeter square should be excluded, because there is always an obstruction after implantation. And between 100 and 2,000, it is our experience, it is a case-by-case analysis, and we can sometimes have good results without obstruction. So in these patients, the value was correct, and we decided to implant SAPIEN 29 millimeter valve by a transeptal approach. You can see here the implantations in the biplane mode, here in the mitral orifice, and the result after implantations guided by echocardiography, showing a good result without significant mitral valve gradient and mild regurgitation. So the key learning from this case are the need and the major role of a pre- and peri-procedural multimodality imaging for transcatheter mitral intervention. We have seen that 3D echocardiography defines the severity of disease, but misses full extent of calcium distribution in this case. And MDCT plays a key role in this sort of case for sizing the prosthetic valve, neo-LVOT prediction, and outcomes of procedure.
So we entered already the multimodality topic, so we're not using two-dimensional echo alone, we're using three-dimensional echo, and with your second case you have added multi-slice CT in a multi-phase analysis. I think this was very nice. There's another question coming up which refers a little bit both to your first, but a little bit more to your first and the second case. And the viewer via Gmail asked us, is 3D echo so essential for this procedure? Would you recommend it as a must-use item? I think he refers to the MitraClip procedure. And do you think, because the start of the e-valve implantations was firsthand a two-dimensional procedure, but 3D took more and more over. So would you say 3D echo is a must-have for a MitraClip procedure?
Yes, we can see it now. Of course, we need to have 3D. 3D allows also explain images and for procedural screening and for procedural guidance. It is an indispensable tool.
Okay, very well. So I think the audience is actively participating in this webinar, which is very good. And we're now moving on with the multimodality imaging, actually to another topic, Felix, that you're also doing at our institution, and this is periprocedural fusion imaging. Can you elucidate a little bit what this is? Can you define this a little bit and then go perhaps into cases?
We have these fantastic imaging modalities. Why not combining, fusing them onto one screen? And I show you this slide as sort of an opener into the discussion, and you see the just mentioned X-plane image of a mitral valve on the left panel, and on the right panel you see a fluoroscopy image with a MitraClip device and the overlay of an intercommissural two-chamber view. And imagine you only looked at the fluoroscopy image without the echo overlay. You had no idea where you exactly were in regards to the mitral valve, and with this echo image on top you perfectly know that you're just above the central region of the mitral valve, A2, P2 region. How does this work? So you need to take echo information and fuse it, marry it to your fluoroscopy machine. And this is done by creating a 3D complete volume and then giving your fluoroscopy machine or the software that combines the two information about the position of the TEE probe. And you fluoro the TEE probe from the RAO and from the LAO. And with these three informations, the fusing technology knows exactly, okay, if my TEE probe looks into this direction, then I have the correct anatomic information of the heart looking like this. And to be more illustrative, I show you what the third generation of the Echo Navigator is capable of. And what you're seeing here is a segmentation model of the individual heart of this very patient. It was taken a 3D volume, it was then rendered and segmented and now displayed in the right correction. And you see the left atrium in purple, you see the left ventricle in rosé in the right atrium in yellow, and you see a wire crossing the interatrial septum. And I found it absolutely fascinating to correct my understandings of fluoroscopic imaging projection planes. So I'm addressing a question to our audience: what fluoroscopic projection plane resembles the three-chamber view we so very well know from echocardiography? Is it LAO? Is it more caudal or cranial? Is it RAO? Or is it RAO, cranial or caudal?
So now the vote is open for the viewers of this webinar. We have 50 seconds open, and I think this is a very important question because when we came from coronary angios and LV angios, actually the answer there would already be given. But it will be very interesting to see what we really see in all those different angulations. And I'm very, very curious about the vote of our viewers who are mostly cardiologists and are using actually all these C-arm projections quite a bit. So we will discuss this, I guess, in about 10 seconds to really know where we estimate to have the different viewing possibilities: 3-chamber view, 4-chamber view, and 2-chamber view. So the poll is over. And it is also quite interesting result, actually. So I think there is a learning objective also on this topic. So the readers and our users are well aware that the REO30 projection may not be the total answer, which is already pretty interesting, because this is normally used in LV angios, and only 15% of our viewers believe that this is the correct angulation. It is interesting to note that both LAO projections, on the other hand, gained a 10% in a caudal projection, which gives you the en face view to a valve, which gives you the mitral valve actually looking from above or below, from the ventricle.
So-called single chamber view.
The single chamber view. And the other view that you will further elucidate, which is the LAO45 cranial 30, which actually got most votes. 40% believed that the LAO45 cranial 30 is a 3-chamber view, and you will, I know, shortly show what it is really. And then we have 23 in REO30 cranial 20, and interestingly only 13%, which is the least number of all votes in REO40 caudal. And now please, after this interesting poll, I think it is good to watch this webinar and see the results by you, Felix.
Exactly. Sort of, it makes sense that you've dialed in, so to say. This is, you could cheat, of course, or you could have cheated by reading and evaluating CT data sets, but I didn't do that before because it's offline interrogation, and you are in the cath lab, and then you want to know directly, and this is what giving you dynamic echo overlay. And here we're showing you a 4-chamber view, and that is actually an LAO cranial projection. You can. So
this was the highest vote we had for the 3-chamber view, so it's a 4-chamber
correct view. The estimations.
It's close.
Yeah, 4 is kind of close to 3, that's correct.
Good.
But yeah, you can appreciate all 4 chambers plus the aorta. So I move on and show you an REO30, so to say, view, which is, as Stefan said, which is what you are trained to use when you do, I only know the German word, when you fill the chamber with contrast. So
right, so this is the LV angiogram.
The LV angiogram, thank you very much. And you can tell here that the aorta, it has the pure overlay with the mitral valve, so that's the intercommissural 2-chamber view.
If we stick here perhaps, because I think there's another thing that is quite interesting for our viewers, because this is a webinar on transcatheter repair techniques or replacement techniques, and this is that we have an overlay in this projection which is widely used of the aorta and the mitral ring, and we chose to show you somebody with a mitral ring, a complete mitral ring. As you can see here, it's coming as an overlay. Now it's moving with the model. Now it's not moving because the fluoro is put on and off. Exactly. But you can nicely see that the aortic root is actually overlaying the mitral. So you cannot differentiate if you want to put a wire either in the aorta from an apical access. You cannot differentiate this view,
you have the wrong
mitral
projection, exactly.
and the aorta.
So if you want to separate inflow and outflow of the left ventricle and cut in a 3-chamber manner, it is actually the REO caudal projection that gives you the right cutting plane. So this is a pure 3-chamber, a real 3-chamber view of this patient's heart, and if you want to do it by fluoroscopy, it's REO caudal. So, and what is actually very interesting in this regard is that when you try to combine both worlds of echo and fluoroscopy, you find out that the spatial reference frame is different in these two, and that what makes it even more difficult to combine, and that maybe we need to come up with a more precise and language that addresses probably the real anatomic situation. Because if you look at the mitral valve here in the surgical view, as it said, it's surgical reference. It's the lateral commissure, the medial commissure. And if you look at the fluoroscopy, it's obviously a 2-chamber view, as we just learned, with the 3 mitral clips put in the A2, P2 region. And if it had the same reference spatial reference where I put anterior should actually be lateral, because the right part, the right side of the intercommissural view by echo nomenclature is lateral. So when you start to fuse, to actively fuse those two worlds, you also realize there's different anatomical references for two worlds. But to take you even further into fusion of echo and fluoro, I'm showing you this because it gives you an idea on how it increases device steering. Is it running again? Exactly. You see a MitraClip device in the left atrium, and you see the marker on the right panel. It says left upper superior vein, pulmonary vein. And as you can sort of control in the true view image on the left panel, the mitral clip is actually sitting behind the ridge in the left upper pulmonary vein. And again, look at the fluoroscopic image without the overlay. As an experienced interventionist, you know how to read your catheter behavior, but imagine you're doing this for the first time. It's actually very helpful that you're displayed the anatomic boundaries.
Perhaps we give a little background to the user what photorealistic imaging or true view is, because you gave true view. It is just a different rendering technique to take conventional echo images, actually normally RF based echo images, and they can come from any echocardiography source. They could come from an ICE catheter, they could come from a TTE, they could come from a TOE. And what the software does, it's a software that's actually developed with the help of Pixar Industries, so a Hollywood company, actually more in cinema productions, like Cars and others. So you can nicely see that the tissue visualization with this rim, where the MitraClip is crossing from the left upper pulmonary vein down before the ostium of the left atrial appendage, that this rim depiction, etc., appears much more natural, and that we have light sources and shadows, something we see in natural surroundings. But for the sake of time, I think we will continue now.
We will go on, exactly. So this is why I'm presenting a third case, a 75-year-old male patient that presented with shortness of breath. Workup showed dilatative cardiomyopathy as the underlying disease and severe secondary mitral regurgitation. Pulmonary artery pressures elevated, moderate tricuspid regurgitation. And the morphology of the mitral valve with the predominant annular dilatation in antero-posterior orientation close to 5 centimeters and only mild tethering. Heart team decision voted for percutaneous annuloplasty. And for those who did not think directly about this CE-marked device, I'm showing you how this works. It's the Cardioband device that anchors a tissue band around the posterior part of the mitral annulus, which is then cinched by a wire that runs inside, which is shortened. And as you can figure out easily, this is a complex procedure. This is heavily based on multimodality imaging. And the question again is, can't we take information into the hybrid OR and fuse it that beforehand was separately? So my question to the audience is, what image modality should be used peri-procedurally during the procedure in the hybrid OR? Is it very basic? Is it only fluoro 2D echo? Do you have to rely on 3D echo? Do you use CT? Do you have to use CT for planning? Or do you even need to rely on CT and fluorofusion? Or do you only want to do this if you can fuse all your 3D information, be it from CT or echo?
The poll is currently open, and we have remaining 38 seconds for you to vote. I think, of course, the prevalence of the different techniques, and we also got, for the meantime, another question from the audience, how and when to train at all for these new modalities and these evaluations. This question is coming from Belgium. So what would you say? How can you train at all for all these very nice new tools?
Of course, you need to be lucky and work in a place where it is provided, or you need to come to visit Mainz. It's also a possibility. No, but I mean, the start would be to look at 3D images and multiplanar reconstruction in a way also fluoroscopy is looking at the heart and try to get things together also behind your forehead, and then of course starting to use this dynamic and newest generation echo and fluoro fusion is tremendous.
I think you were very convincing, and the viewers of this webinar are actually also quite well informed. So nobody voted for fluoroscopy and to do this procedure solely on two-dimensional echo. The lowest number of participants already wanted to go for fluoroscopy and 2D, 3D echo only. The majority actually of voters had two preferences. One is the current reality, which is fluoro, 2D and 3D echocardiography and CT planning. This vote got 1/3 of all viewers. And the majority actually, and this shows that even with the first images, you showed quite convincing pictures, is with more than 41% that fluoro, 3D echo, CT planning, and some sort of CT echo fusion would be the preferred imaging modality combination actually to perform this procedure. So we had combined a vote of more than 73% actually for these current predominant ways to do this procedure. So I think this is an extremely well balanced poll here that we see here. And we ask you to continue, Felix.
Very interesting indeed. I mean, just to say it now, I think it will all go into the direction of answer number 5. But when we treated this patient, we did not fuse echo and fluoro information. But what we did do is we had CT planning in a multiplanar interrogation of the CT scan, and what we did do there is that we defined anatomic landmarks like the trigons in this case and the commissures of the mitral valve, but what we also did is that we defined the landing zones. And in this CT fusion software called Heart Navigator, you can set up to 10 markers, and we put these markers around the mitral annulus, just where we were going to implant the annuloplasty device. Well, offline CT planning also helps is to define C-arm angulations. You have your heart segmented, and you can rotate the heart model just in the way that you can either have the en face view, like in the single chamber view, which is LAO 43 in a chordal angulation, and you can also rotate your heart that you have the two-chamber view and an RAO 37 projection. And what this looks like throughout the procedure I'm showing you here, you see the CT information overlay, you see the aortic valve and the coronary sinus, and you see our 10 markers which are defining the landing zone. And what we also marked was the ostium of the coronary artery, and if you look at the right panel, you see the top yellow circle, and you see that the overlay with the coronary ostium is very well done, because you can see the coronary angiography. And then finding the first spot for the first anchor is crucial if you want to have a good implantation. And you can see that we're now really pointing towards the first yellow circle of our defined landing zone. And this works, of course, at the beginning of the implantation, but it also works when you're at the end. You can appreciate here that obviously the heart is moving, and this CT overlay is still non-dynamic, so of course it will be a big advantage if also the CT images are moving. But it gives you good feeling and information on how far you've gone around your heart and how many more anchors you want to implant.
Felix, if we could just highlight what are the green markers. Actually, they are automatically given. So the yellow markers were the ones we put manually on the ring for the anchor landing zones, but the two green markers are surgical zones. So one is the end of the leaflet and the other the trigon.
The bottom one is the commissure, exactly the commissure of P3 and A3 scallop, and the other green circle is the posterior medial intertrigon, where you want to end with your band. So this is last slide for this patient, showing the implanted annuloplasty ring in the bottom left panel, and on the right side you can see a significant reduction in mitral regurgitation. Just to go quickly through another case that uses, of course, multimodality imaging, and which refers to Eric's case where he implanted a SAPIEN S3 in a native ring. We're showing you here fluoroscopy images of a valve in surgical ring procedure. And next to these fluoroscopy slides, we of course also need our echocardiography, our 3D echocardiography. And again, we're showing you these true view images at the bottom. And what you want to appreciate here is that how these new 3D technologies help you evaluating mitral valve tissue quality. You can appreciate in the left bottom panel that the light source is in the left atrium, whereas in the right bottom panel, the light source was moved virtually into the left ventricle. And you can appreciate how heavily tethered the posterior leaflet is. Whereas in the opposing panel with the light source in the left atrium, that is not as easily done. So skipping into the procedure again, of course, multimodal imaging helps you to put your wires into the ventricle and to position the valve. And that all ends up, in this case, into a very nice result with an S3 valve beautifully positioned and working in the annuloplasty ring.
Very nice result, and we see that there is no perivalvular leak. That sizing is very important. You see also on the rotational fluoroscopy on the right-hand side that we have an excellent seating inside this complete ring, and that we also closed, in this case, the interatrial access with a cardioform occluder. I think it's an excellent case presentation, and we will have ongoing questions for this that are already coming from our viewers.
So I can kind of sum up my experience that I had with fusion imaging. And of course, you run into colleagues that say, do we really need this? Isn't this overlay more confusion than fusion? And other ones say, I have a graphic processor that does not need overlay. I do this behind my forehead. But as I hope to have taken you, it really boosted my understanding of fluoroscopic projection plane, and it also facilitates catheter and wire handling. So I think we do need this.
Excellent. So we will come back now at the end of the webinar to address further questions, and you're still invited for the remaining 10 minutes actually to send us further questions into the discussion, and we'll be more than ready to answer them in this webinar, but also after this webinar. So one of the questions here that relates to your talk, Felix, is this fusion image accurate? Is this technique needing a breath hold? So this is one of the viewers that is interested in this information. Can you elucidate on this?
No, regarding echo and fluoro fusion, you do not need a breath hold. You need to hold your TE probe very stable in that moment that you merge echo information and do your sinus of the TE probe. But as soon as they're married, as I say, there's nothing you need to focus on. It's sort of set up, and the trick is that the fluoroscopy machine tracks the TE probe all the time. So you can do the most awkward angulations as long as the TE probe is visible in the fluoroscopy image. The machine calculates the orientation of your heart and gives you the anatomic information. Another interesting and important point is that you have a dynamic overlay, of course. If you want to, as opposed to the CT overlay I showed you, it was non-dynamic. The feeling that you're really closer to the heart and really and witnessing a real image of the heart, the dynamic overlay is very important.
There are more questions coming in, but I would also like to stress that we have two different potentials that you showed, which are simultaneous. And one is a on-the-fly correction while you do fluoroscopy. The probe position is again controlled for live overlay of echo images. This did you show at the beginning of your talk as a teaser. and the model is actually referred to the patient position on the cath lab table. So no matter what imaging modality and what view you take during the implantation, the once defined view of the model to the patient's position and to the C-arm remains totally stable throughout the procedure, and you have to recalibrate it, of course, if you move the patient on the table. But the cath lab table itself can be moved freely, as well as the C-arm or the echo probe. So you don't have to maintain a certain position for the echo probe. You can go transgastric, you can move out, in and out.
Even though transgastric is obviously mathematics to follow transgastric per position are the most challenging ones. So overlay is more complicated when you do transgastric imaging.
One question before it goes out of my screen here, because more and more questions are coming in, is again referring a little bit to Eric Prochet's presentation. And people are asking, and I think we should differentiate this a little bit more, with reduction of LV volumes and dimensions past MitraClip, does a neo-LVOT obstruction also happen subacutely with a MitraClip procedure? I think this is very important to differentiate this from your two cases. So one was a valve design, TAVI valve, in a native mitral annulus, and the other one was a treatment of a prolapse in a MitraClip. So does there also happen some LVOT obstruction? What is the problem there, or can it actively help if you have a SAM or a HOCM? Can you elucidate a little bit on this, Eric?
Yes, it's a very important point, and as you said, MitraClip therapy is a treatment of the valve, and as the valve move less after implantation than before, and there is no risk of LVOT obstruction after MitraClip implantation. And as you suggest, it is also a technique that has been proposed for patients who had a SAM, and very successful cases have been reported showing treatment of hypertrophic obstructive obstruction with this technique.
Okay, staying with you, we immediately go to the next questions, and more questions are coming in. So is there an upper limit for the annular size in mitral valve replacement at the moment? So I think there is, of course, because of the valves we use. Can you reply on that?
Yes, of course. As regards the MAC implantation, above 6,500 centimeters square, generally it is too wide for implantation of a 29 Sapien 3 valve. So there is a limit, of course, and many patients are excluded because of this cutoff. Yeah.
So even with an overexpansion, we reach a maximum of a diameter of 3 centimeters approximately. Yes. Okay, that's important for the audience and has been many times asked here. As an echocardiographer, how can I help in preoperative assessment in sizing the annulus? Or do you prefer other imaging modalities for sizing only? So can the echocardiographer also do something to get an estimate? It refers not only to MAC, it refers to all different modalities. Do we have to size the annulus? How do we do that? That's a very often asked question here.
Yes, I think it's a good example of a multimodality approach. We can measure the annulus very well with a 3D TE, with the different planes. And as we have seen, multiplane reconstruction is a perfect tool to measure a mitral valve annulus. When you align the different planes, you have a cross-sectional cut of the mitral annulus, and it gives you very accurate measurement of the annulus also.
That's a very important point, to stay anatomically direct, as you pointed it out in the beginning, Felix. There's another question, perhaps addressing you both. Should you have only one modality to monitor intraoperatively, selected for TMVI, so mitral replacement, or TAVI, so aortic replacement by transcatheter methods? Which one would you choose for which case? So doing a TAVI, if you want to do that, if you had only one modality, what would you choose? You can answer both. And if you do a mitral, in a mitral, I think it's more difficult, the question.
Well, actually, if I understand you right, if I only had one imaging modality,
a prime modality, I think we always.
But you can even go further and actually ask yourself, if one machine breaks down, I mean, you cannot do a TAVR obviously without fluoroscopy.
Yeah.
And I'm actually convinced that you can do it without echo. TAVR will do without echo. And if you did not have a running fluoroscopy machine, would you do a mitral clip only based on echo? Probably you could.
Yeah, you could, but you wouldn't, I think. I think
course
there's a
you
safety
wouldn't.
issue, and I think...
Of course you wouldn't, but
Yeah.
I mean, that stresses what modality is predominant in those two interventions.
So there's another question for you, Felix, and our viewers are really active, I have to say, and there's another Gmail question before we come one from the Netherlands. In your experience, what are the pitfalls of using fusion techniques for both the echo fusion and the CT fusion? So what is the pitfall for each of the two techniques? Are there differences? Are they the same? When do you use which?
I mentioned that the non-dynamic overlay of the CT I showed you does have the pitfall that you have a moving object and you may relay on your static overlay. So you always have to keep in mind that the landing zone, for instance, we defined for implanting the annuloplasty ring has a different position in systole and diastole. The pitfalls in echo fusion, they're very few, I think. Of course, actually that's interesting. I showed an example where we pulled back a MitraClip device out of the left upper pulmonary vein, and you look at your 3D augmented overlay, and it gives you the idea that you really see everything of the left ventricle, but still you only have one projection. So it can't be that when you look from the other side, you are still outside the heart chamber. So you cannot, like in normal fluoroscopy, you may be in that projection. You may look that you're right, but if you look from the other side, you may be outside. And only because you have an overlay, it doesn't mean that you must not be cautious anymore, that you're really in the right spot with your device.
But this is a pitfall rather of the display technology that we're using nowadays, and I think there's also upcoming tests now on holographic and augmented reality views actually for the cath lab, so that we really see via double projection, via polarization filters, that we get more depth information. And
if you could easily turn if you work fluoro-based, you need to have, when you want to look from the other side, you still need to turn your C-arm. But if you had an endless number of C-arms, of course, you could probably work only in the virtual model.
So as we're approaching the end of this webinar, there are more and more questions coming in. We try to answer them now in about 15 seconds. How does morphology of the valve or the annulus influence your choice of mitral valve repair devices? MitraClip versus Cardioband versus the Carilion device. So just a very short answer here, 15 seconds.
Okay. The more it is Carpentier 1, meaning annular dilatation, less tethering of the valve, of the leaflets, the more it is annuloplasty, and the more tethering you have, the more it is MitraClip.
And the Carilion device is dependent on the coronary sinus morphology
Good
and
point.
the crossing of the circumflex. Very good. Last question that we'll address: how can I apply for cardiac imaging training or fellowship in the Mainz Heart Center or Heart Valve Center? Felix, how can we do that?
That's quite easy. You either write an email or pick up the phone.
Very good.
Anytime.
So as we got this straightened out, we will now go to the closure and we'll take a short look at our 3 main take-home messages for today. So we have seen transcatheter repair techniques in multimodality imaging. We're not going so much into indications. There were also 1 or 2 questions on indications for our open heart surgery versus transcatheter methods. That was not the scope of today's webinar. We were mainly focusing on imaging, and we were only focusing on the mitral valve. So we had to exclude those questions. Multimodality imaging, I think, is needed to diagnose, plan, and treat complex mitral valve disease, and I think all 3 cases and also the 4th example very well suited to actually show these arguments. Fusion Technologies, and we spoke about the limits, but also the advantages, combines multimodality information into one image display. And this display, of course, also can get better in the future. And perhaps it's a helmet with which we are operating in the future. So future quality and speed of multimodality integration, as well as the operator use models or skills, will further advance as we use more and more this technique. So I will now conclude this EACVI webinar, the first part on the mitral valve for multimodality imaging. I wish you a very nice conclusion of this webinar. We thank you about the nice interaction and wish you a nice training perspective for all these new techniques. Very well from all three of us from Nice, the ESC Heart House. Thank you very much.
Bye-bye.
Goodbye.
Thank you.